So I'm going to talk about cardiac amyloidosis. We think it's rare, but it's not actually very rare. And the more I've been in this field, I've realized that people just don't recognize it appropriately. So since we have a mix of different cardiologists and people coming from different backgrounds, the content here would be sort of highlights. And if there are any questions that you want to discuss in detail, I'm available after the talk to discuss that. So let's get into it. Let's first try to understand normal. So you have a code book, you have DNA and RNA, so the product of that is protein, right? So, and normally appropriately produced protein gets folded and then discarded in our body. However, what happens with amyloidosis is that it is a protein misfolding disease. And because of the misfolded protein, it actually deposits in different organs, leading to progressive organ failure. This is what really goes wrong. Normal protein, as you can see, is nice green, nicely folded, has a nice shape, but the abnormal protein at the door are just as strong. And it basically deposits in all the different organs and accumulates over time. And it can be many years before you actually manifest anything. Some people have been accumulating amyloid for many, many years. So why does this misfolding occur? In certain types of amyloid, we don't understand. In other types of amyloid, for example, the one related to variant transthyretin amyloid, we know there is a genetic mutation. Why does wild-type amyloid occur? We don't understand that. And why does AL amyloid, which is a sister disease to multiple myeloma, lead to amyloid deposition is an unknown, but there's a lot of work being done on it. My focus today is light chain amyloidosis and transthyretin amyloidosis and how to recognize the differences between the two. If you can do that in your workup with patients, that is what makes it easier. So light chain, approximately 3,000 new cases per year. For me, I see up to 25 to 50 patients of AL amyloid because of at Center of Excellence. We do transplants also for AL amyloid. And transthyretin amyloid, I see up to 400 to 500 patients yesterday. They were full day clinic yesterday, and out of which, out of the 20 patients I saw, 8 were amyloid. So it just depends on how well you recognize it, where you're at, how often you can see it. So what really matters is the production site and the type of protein, which is how we define it. And for cardiac reasons, we are only interested in AL amyloid and TTR information. AL light chain is produced by plasma cells, and it can be kappa predominant or lambda predominant. So those are the two relevant light chains, lambda and kappa. And depending on which one is being produced in excess, is basically determining which type of amyloid is being developed. Now, it is important to understand that there has to be a disproportionate rise in one particular light chain. In chronic kidney disease, you can have rise of both chains, lambda and kappa can equally rise, but that does not mean you have amyloid. The other one is transthyretin amyloid. The function of transthyretin is to carry our thyroid hormone and vitamin A. It's produced in the liver. And as I mentioned, there's a genetic abnormality or the wild type. Why do we care? Because it can lead to restrictive cardiomyopathy and progressive heart failure. It can lead to atrial and ventricular arrhythmia, so people who have atrial fibrillation, diastolic heart failure, and a thick heart, think about amyloid. In conduction diseases, particularly bradycardia, most amyloid patients die from bradyarrhythmias. And then also ventricular arrhythmias, but bradyarrhythmias are very common. They also have microvascular ischemia, so a lot of patients will complain of chest pain. Normal heart is when it's like a balloon, it fills up with blood, it's compliant, it blows up, and when it relaxes, it just squeezes back into normal. But in amyloid, most patients have a heart that becomes thick like a cup, so that's diastolic heart failure, it's a non-compliant heart. And then some patients can also develop systolic heart failure, which is the big bad in the body, as I explained to patients. There is some difficulty in diagnosis, but as the awareness continues to occur, more people are being diagnosed sooner, but there's approximately delay from 5 to 10 years between the time the patients actually develop symptoms to being diagnosed. A lot of times being told that this is in their head, and they see at least 5 different physicians before they actually get the diagnosis of amyloidosis. Timely diagnosis matters because we can do targeted therapy. In this day and age, there is a lot of therapies available, and recognition is rising, but despite that, as we know, there's a significant delay. Now this is the algorithm, so I'm going to go over this very briefly. Step 1 is to suspect amyloidosis. And and we're going to go over some symptoms that occur. That's patient history, physical exam, initial lab test. So for particularly AL amyloid has tropism to different organs. So it can involve the heart, the lungs, the eyes, the brain, the nodules in the lungs. So it can lead to proteinuria. So there's a lot of different organs that get involved. For TTR amyloid, the predominant organ is the heart and nerve. So those will be the two that we suspect. In AL amyloid, sometimes the symptoms can be non-specific. It can be fatigue, weight loss. They may have, again, heart abnormalities. Foamy urine is a very common symptom that occurs because they have proteinuria, they have neuropathy, easy bruising. You know about the panda eye, where they have developed periorbital hematoma. So depending on which organ gets involved, it's common. Other things are like new onset sleep apnea, particularly in somebody who's young, enlarged tongue. So again, an array of symptoms. So AL amyloid can be a little bit more sort of challenging if you don't recognize the symptoms. But for transthyretin amyloid, which is what most people in this room will end up seeing, is there are certain red flags, and these are very simple things that you can ask in clinic. So bilateral carpal tunnel, lumbar spinal stenosis, biceps tendon rupture. You know, it literally takes you 3 seconds to ask these questions. And then neuropathy in the absence of diabetes. Undiagnosed neuropathy. Why did you have neuropathy? Okay, I've never had diabetes, so you know that's a red herring there. Intolerance to goal-directed medical therapies. If you put somebody on Entresto for heart failure and they're not tolerating it well, I mean, yes, you should think about it, particularly if you have a big heart. FBEF. Aortic stenosis, up to 10 to 15% of patients who have actually aortic stenosis, history of aortic valve replacement, do actually have hypertrophic cardiomyopathy. Newly diagnosed hypertrophic cardiomyopathy in elderly patients. So that is a red herring too, because it's a phenome mimicker. So I've had patients who were diagnosed for years at a time with hypertrophic cardiomyopathy and actually did have amyloid, not hypertrophic cardiomyopathy. Family history of sudden cardiac death. Again, imaging clues, which is again a thick heart. Most people ask me the threshold. If you really want to be specific, 1.5, but that doesn't mean that below 1.5 you can't have amyloid. I've had patients with a heart wall thickness of like 11 or 12 millimeters and they do have amyloid. And then again, arrhythmias and heart block. But these are like big symptoms, and then of course orthostatic hypotension, diarrhea, these type of symptoms that go along with it. Then the next step is to verify diagnosis. So first step in diagnosing any type of amyloid, which is you're only dealing with 2 types of amyloid, AL and transthyretin, is to screen for AL amyloid. So why is that important? So first of all, you have to look at the kappa, lambda, light chains with immunofixation. That's very important to state that, with immunofixation. The reason behind that is that, one, you have to see that the chains are disproportionately high. And second, these proteins can be very small, so if you don't do immunofixation, which is an additional step, sometimes they cannot be recognized on just the serum evaluation. Then we look at the ratio, so typically the ratio between 0.26 to 1.65 is considered normal. However, patients have chronic kidney disease and they're already producing a lot of kappa and lambda light chains, their ratios can be a little bit off, so you can use a bigger confidence interval is how I explain it. And once you've recognized that there is an abnormal protein spike, and you have recognized the protein by either urine or serum immunofixation, the next step is, of course, a lot of people get worried about this, and the most common phone call I get is whether this light chain is abnormal. Some degree of abnormality is not very convincing, but as I said, if the ratio is above 1.6 or even above 2 or below 0.2, that's when you consider it abnormal. But happy to take that phone call if it becomes confusing. But a lot of people then refer to hematology, which is also fair. So that's the first step. Now, if it is completely negative, right? This slide I'm going to skip because I talked about GFR. If it is completely negative, right? So then we go down the algorithm along this path. So there is no abnormality in the serum light chains, and then you can do a PYP scan. We'll repeat this again. If this is normal, then you can proceed on doing the PYP scan. If this is abnormal, do not do a PYP scan. The reason behind that is you could have AL amyloid and may have a false positive on the PYP scan. So then you're treating the wrong disease with the wrong therapy. And imagine somebody with multiple myeloma and you start treating them with tafamidis. You're doing them a big disfavor. So if it is abnormal, then of course you go out to do a hematology consult and so forth. And usually we have to do a biopsy of the endomyocardium, which we prefer doing because if you have FPL amyloid deposition, then you will get the 99% of the time you will get the right diagnosis from it, followed by mass spectrometry. If it is not abnormal, just doing a P by P scan and looking at the grading on imaging will sort of lead you to the right diagnosis. And the next step after that is to do genetic testing. Why is genetic testing important? Because we want to understand whether this is variant or mutation related ATTR cardiomyopathy, or it is wild type, which is just age related. So this is basically the long and short of it. And then you have somebody that, for example, you're suspecting AL amyloid and kappa lambda abnormalities, then you have to, and you don't know if they have heart abnormalities, then you have to do, of course, the echo, the MRI, to confirm that they have heart abnormal or not, and then, of course, doing an endomyocardial biopsy. But these are some imaging tools that we use, and again, echo with wall thickness, the cherry on top, which is nice to see, but is not always there. And of course the P by P scan, which I'm not going to go into details of today. There are greater than 130 mutations. I really want to know which mutations are common in Pakistan, but I not have the opportunity to do so. I've seen a few Pakistani patients with AL amyloid, but not TTR amyloid so far. Maybe you don't recognize it. There is a specific panel for amyloid that is pre-testing available, so it's very easy to do. In pre-testing, they only test for the transthyretin gene. In the panel tests for phenome mimickers as well. So for example, in an amyloid panel, there is genes for hypertrophic cardiomyopathy, there is genes for Lann's disease, and there's genes for Fabry. So if you are on the wrong track for diagnosis, that panel is foolproof. Typically, if I'm not convinced that somebody is amyloid and they have a restrictive phenotype, then I do the full panel. But if I'm really convinced that they have amyloid and I'm just confirming their genetic, if they're genetic or not, then I just do the pre-test for them. Why does it matter? First of all, of course, you have to understand which stage they're at. Let's talk a little bit about treatment for ATTR cardiomyopathy. We typically stage them by using the troponin and NT-proBNP. Both are negative, they have stage 1. If both are positive, they're stage 3, and then they're in between. Why does that matter? Because it really correlates with prognosis and if they're responding to treatment or not. And as you can see, the survival curves are worse in patients who are at a higher stage. How much time do I have? 2-3 minutes? Okay. Okay, so I'm going to talk really fast. But this is somebody who had ventricular tachycardia shock. They had presented with bradycardial junctional rhythm, multi-organ failure, the heart looked kind of funny, and I asked the wife and she said he had bilateral carpal tunnel. This is on his deathbed. We recommended doing an autopsy after he passed away. He wasn't going to make it, and lo and behold, he had basically amyloid literally everywhere in his body. And surprisingly, he had wild-type amyloid, and we did mass spectrometry and the genetic test was negative. So mass spectrometry is a test where they take the tissue and send it to mail and determine what type of amyloid you have. Do you still proceed with genetic testing? The answer to that is yes. So I took a vial from that patient. Unfortunately, he passed away, so I call it molecular autopsy. So after his death, I took a blood sample and sent for genetic testing because mass spectrometry does not detect all types of genetic things. So you still have to do a blood test. But it was negative, and so he had this type of variant. This case I just want to highlight is because this is somebody who is typically what you'll see with a 74-year-old who had atrial fibrillation, who had persistent left atrial thrombus despite anticoagulation. So he was placed on warfarin, and he was switched to Eliquis, and he was pushed to Xarelto. So all that, multiple layers of anticoagulation, but that thrombus refused to go away. So they decided to do a surgical excision with this patient. And then post-operatively, I got called because they couldn't get the patient off of the balloon pump. His filling pressure was super high, cardiac index was extremely low. So I go and talk to this lady, and she's looked at the history, and she basically had carpal tunnel, neuropathy, spinal stenosis, undiagnosed neuropathy for many years. And lo and behold, I thought this is probably amyloid. So we did, I told the pathologist to stain the left atrial appendage that they had excised. was positive for amyloid. So that was one like important thing. And then she actually had we sent a genetic test. She was Irish, so she had this ProSER variant, and so that's very common in the Irish population. So all of her family who has tested so far, I think 15 members are positive for this. She unfortunately died. So we had waited for an outpatient workup, then that would not have been a good thing to do. So, okay, treatment. I'm gonna just really high level. For steady-state amyloid, we have an array of a slew of treatment modalities. We used to transplant livers for patients because we didn't have a choice. But now, if you don't need transplant per se, you can have silencers, you have stabilizers. We just finished enrollment for a clinical trial for depleter, which is actually an agent that takes away the amyloid protein from the heart. So we have all these options, and they're approved for both wild type and variant transthyretin amyloid. I think I'm going to stop here because I don't know if I have time to finish therapies. But if you all have questions, then I can finish the therapy slides.
Thank you. It's very difficult to do this in a few minutes. But just in the algorithm, when you're talking about the diagnosis of P by P scan, we understand the grade 2 and 3, but you said or heart-lung ratio more than 1.5. If you're using oxygenate, you can't even do that.
Correct.
But also, if you're just using SPECT, and so can you comment, because the more I learn about it, they say the heart-lung ratio is not something that you should do.
Yeah, definitely. This is sort of like in some places where they just don't have, the ability to do, but, typically we use grade 2 and 3, we do SPECT CT, we do the first hour and 3 hour washout again. So I think that there will be some cases which look sort of intermediate, you're right, we don't usually, worry about the heart-lung ratio, we look at the...
Do you report that in your...
We're not reporting that.
Well, if I just a little housekeeping, because all of you asked, we're actually videotaping Harley and Emily. You should have all this videotaped, but we want you to get up and speak really loudly so that whoever is watching this can actually. We'll put this on YouTube and stuff like that.
And also, Raza, can you please repeat the question that was asked?
Very loudly. Yeah,
because it come in the video.
So the question was whether we the heart-lung ratio, it's sort of a little bit outdated. So we try to look at the rating like fixed rate of grade 2 or 3 and so forth. So we're just talking about how SPECT CT is a better way to do it. We typically do 1 hour, 3 hour. But that was a question related to the algorithm. But in some places, we use the heart-lung ratio.
All right, thank you, Kasi. So we have an extra mic as well for the question answers. I'd like to introduce one of our other co-chairs who's here, Temur Gill, interventional cardiologist here in Dallas. Thank you for joining us.
Thank you very much for attending this session. Our next speaker is going to be Dr. Fayyaz Hashmi. He's an eminent cardiac surgeon, has served in the US for many, many years, but most importantly, he's serving the very needy population in Pakistan with respect to rheumatic heart disease. He's done a lot of work there. It's our privilege to have Dr. Fayyaz Hashmi as our next speaker. He's a retired assistant professor from Johns Hopkins and still works in that area. Dr. Hashmi, please.
This really is an honor to be here. I didn't expect myself to be addressing a group of august cardiologists. I'm just a technician. I retired from Hopkins last year, but we started a global cardiac surgery outreach initiative 2 years ago, and part of my work is under that umbrella. We're doing a project in Pakistan as well as in Africa and Burkina Faso. There are challenges. At the outset, I must say that rheumatic heart disease is an orphan disease. It's a disease of the poor. And so not a lot of attention has been paid in the last 70 years. But I think in the last about 6 or 7 years, there has been more recognition that rheumatic heart disease has been devastating lives and families. So there's so much to do, and there are big challenges. First of all, there is an imbalance between the disease burden and the resources. And the resources are, as you know, we are part of in Pakistan, we are part of the low and middle income countries. And even in the middle income countries, we are at the bottom of that group. And then there's a problem with manpower, and then that, again, the infrastructure is not there. And it is imbalanced because there are concentrated infrastructure in urban areas, but there's a vast rural areas or distant areas that there is no infrastructure present. Then, of course, there's a burden is congenital heart disease, the rheumatic heart disease, and the atherosclerotic disease. This is just to give you a perspective that by 2030, there will be 25 million deaths from cardiovascular disease. And if you look at just the resource perspective, the low-income countries, the daily, per day is $2.5 a day. And Pakistan is just skimming the treetops. Pakistan has a gross national income of $1,500. As compared to the United States, if you can see at the bottom is $77,000. And there's the whole spectrum of countries in between. And if you look at the South Asia, just look at from the 1961 to 2021. That's a 70-year perspective. And Pakistan has not caught up with India and Bangladesh. We are at the lower part of that spectrum. And that's from Bartlett Bank. Now, as I said, it's an orphan disease. It is a disease of the poor. One of the biggest factors is the social determinants of health. And if you look at that, there are 5 major social determinants: the social contact, the housing conditions, the health status, the health literacy, and the access. And all of these contribute towards the evolution of rheumatic heart disease and death. The group A streptococcal infection comes because there is overcrowding, and then there is the housing and their service, meaning there are no washing. They don't have running water to wash their hands, for the hygiene and stuff. And then again, once the infection occurs, then the rheumatic heart disease, the acute rheumatic fever develops. I'm not trying to give you the medical aspect, but just this is important to remember, because this is what is being dealt with in Pakistan. And there's malnutrition, there's low immunity, there's mental health issues which then contribute towards the development of acute rheumatic fever. And then the rheumatic heart disease develops because of the recurrence of that rheumatic fever. And that comes from recurrent infection from the streptococcus. And then, again, the health literacy is so low that people don't recognize it. The parents don't recognize that their children have problems. And that then leads to the chronicity of the disease. I'm not going to belabor this. You guys know better than I am. Worldwide, there are more than 600 million cases of group A streptococcal pharyngitis. And the highest risk group is 5 to 15 years. Now, because of social determinants of health are so low in Pakistan, we had one of the highest incidence of rheumatic heart disease in the world. There are 1.65 million people in Pakistan who have rheumatic heart disease. And if you look at the economic burden per episode of pharyngitis, it takes about $22 to $400 to treat pharyngitis. And then I'm not going to go into impetigo and other things, but if you develop acute rheumatic fever, the cost goes from $230 to about $6,000. If you develop a clinically significant rheumatic heart disease, which can be managed medically, it is about $1,000 to $40,000. But once you, $500 to almost $12,000. But once you need surgery, which is in the case of severe rheumatic heart disease, the cost goes from $1,000 to almost $40,000, depending upon where you are in the world, geographically. Look at the disease spectrum. You know, if you develop a rheumatic heart disease, it's not symptomatic. There are 3 tiers, and as time goes on, you develop symptoms. And once the rheumatic heart disease patients develop heart failure, that's when they really generally are recognized in our part of the world, or in most of developing countries, or low income and middle income countries. And at the top of it is death from the rheumatic heart disease. Globally, the peak disease manifests itself between 20 to 29 years. So this is when people really start building a life. They're just beginning jobs. Either they're getting married and starting families. Especially true for women. And as I can, initially the disease affects men, boys and girls equally. But as time goes on, women are more affected by the chronicity of the disease. And right now, there are about 12 to 14 million people in this world who have rheumatic heart disease. And Pakistan alone has 1.65 to 1.7 million people with rheumatic heart disease already manifested. So we don't really know how many more are asymptomatic and they're in the spectrum of developing. Their journey is towards the symptomatic aspects of this disease. In 2021, the incidence was 5.7 persons per thousand, and this is one of the highest other than the Oceania, the islands in the South Pacific, where there is healthcare availability. And again, Pakistan has one of the highest disability adjusted. And the dailies are, the sicker the patients are. The less the dailies are, the less severe the disease is. In the developed countries, it's less than 25 per 100,000. In Pakistan, it is almost 600 to 700 per 100,000. This is just to give you a visual of where you can see the dark red amber. That's Pakistan. And then parts of Nepal, and then India, and then you can see in the Papua New Guinea, all the way down to in the Australasia region. What has happened to rheumatic heart disease in Pakistan in the last 30 years? This is a great paper published in 2022. They looked at the prevalence of disease in Pakistan, increased by 134% in 30 years. That is also because the population was probably about 550 million, now it is 250 million, 252 million to be exact. So the population is increased, so the overcrowding is increased. I think fewer people have access to healthcare, although more people have access, but ratio-wise, fewer people have access. And that has increased the numbers. And in Pakistan, 43% of the patients with rheumatic heart disease are younger than 20 years, and they live in the rural areas. So there's a huge number of patients. If you look at the 1.65 million, and 43% of them would almost make 700,000. It's a huge number. South Lahore are sitting somewhere in the hinterlands of Sindh and Punjab and KP and Balochistan with no access. or very poor access. There is health literacy is almost zero. And I'll show you what is the health literacy in Pakistan. I'm not going to spend too much time on it, but there is a foundation in Pakistan, Child Eye Foundation. They run 14 emergency rooms in big public hospitals, including Mayo Hospital. In Karachi, they have about 6 or 7 centers, the civil hospital they run, the pediatric emergency rooms. Last year, in 2024, they treated 112,000 kids with pharyngitis. Now, these are the kids who came to them with sickness, with fevers and cough and colds and stuff like that, which they could not be treated at home because a lot of times people self-treat, self-medicate. So 112,000 in 1 year, and if we increase that, if we just extrapolate that number to the rest of the world, Pakistan, every year 300,000+ kids are added to this disease every single year. So the real issue is, how do we stem the tide right from the beginning? Now there are tests which are available to diagnose the GAS infection. One is the rapid antigen detection test, and the Chinese made is about 500 rupees per test. So that's $1.75 per test. It has specificity is about 86%, but it is better than nothing. So if you have pharyngitis, about 20 to 30% would have bacterial pharyngitis, the rest are all viral. So if you would treat everybody with blanket antibiotics, you're treating a lot of patients with unnecessary antibiotics, working towards the development of resistance to these antibiotics. So the real issue is, how do we get that rapid antigen detection kits to the front line? The most specific test is actually the nucleic acid amplification test, but that's much more expensive. It's almost $300 to $400, and I don't think that can be afforded. So the Chinese made RADT is between $110 to $550 rupees per pop. And I think that's very affordable. $500 is not that much money, it's $1.75. There is a study about surveillance for rheumatic heart disease, and I'll just touch on it briefly. So this is 37 population groups that they studied from Asia, Africa, Oceania, and Latin America, and one in Europe, which is Albania. The pool prevalence goes anywhere from 2.9 per thousand to almost 12.9 per thousand. In some parts of Pakistan, it's almost 22 per thousand. You can just see the enormity of the problem. Majority of these are rheumatic mitral insufficiency. So I'll come to that a little bit later. And then there's rheumatic aortic regurgitation, and then if you just look at the graph, if you could look at this, if you were to diagnose clinically, the prevalence is 2.9 per thousand. If you start doing the surveillance echoes, screening echoes, it goes by almost 20 folds up. So the real, then once you develop it, you can't detect it unless you really are doing a screening. And I'll come to the APCNA's role in that. So anyway, the Masood Sadiq is a very prominent pediatric cardiologist. He's the head of the Children's Hospital in Lahore. In 2004, they screened 25,000 kids in schools in Pakistan, in Lahore. And they found that the incidence is almost 22 per thousand. And 93% of those children and their parents did not know that they had disease. Now, what happened from 2004 to 24, they now, his daughter actually wrote this paper, and it just got published earlier this year, last year, Noor Sadiq. The presentation of rheumatic heart disease in emergency room in Pakistan, 93%, 94% is carditis. So they have already have gone through the whole spectrum from sore throat, rheumatic fever, subclinical rheumatic heart disease, to where they have this manifested carditis, pericarditis, or the multiple. And if you look at the other areas, there's from India is about 72%, and Morocco is 53%. This is a graph form of it. So it's more recurrent. More recurrent rheumatic fever you have, the more valves are involved, and that's what it shows. So if you could look at the orange bars as the recurrences, recurrent rheumatic fever involving more and more valves. Single valve, double valve, and then tricuspid valve starts getting involved. This is not a new phenomenon that we know about rheumatic heart disease. About 100 years ago, 1925, in BMJ, this was an article published about rheumatic heart disease. And then 30 years later, there was another article. This is beginning of the last century, 1944, somebody presented a paper on management and prevention of rheumatic heart disease. So we have known, the medical community has known rheumatic heart disease is a problem all this time. And I'm sure most of you, most of us went to Pakistan, school in Pakistan. And the cardiology wards were full of people that we would go around and learn how to hear the murmurs. So as I said, it's an orphan disease. 7.5% of the patients screened know their diagnosis. So the health literacy is a huge problem. And majority of these 1.5+ million people, 60% would need intervention, whether it is a catheter-based or a valve replacement-based. Now, there are limited resources. And these resources, I'm not going to do this. This is a little diagram about how they handled rheumatic heart disease in the indigenous population in Australia. And now there's a program in the African Union which has this algorithm. And this is a beautiful paper from Pakistan published last month in June. This gives the challenges, the stages, challenges, and the solutions. So it really needs a commitment from the government, from the primary healthcare system has to be set up. Socioeconomic conditions we cannot change, but we can at least do something that we can affect. So I'm a cardiac surgeon. Tayyab Pasha is sitting in the audience, and Tayyab has more experience with rheumatic heart disease surgery than I do, and he can tell you that how prevalent it is in the wards. So what we thought that we need to do something. As you know, that Rome wasn't built in one day. So we want to start a pilot project where we have a registry. We involve the government and the philanthropic organizations such as SAUT, APCNA, Pakistan Cardiac Society, Child Heart Foundation, and the Pakistan Children Heart Foundation. So we got in touch with each one of them, and I'm not going to go through this, but I'll tell you what we have done so far. We started a pilot project at Punjab Employees Social Security Institution, which is actually an HMO. It covers all the industrial workers. Any company which has more than, any company which has more than 50 employees have to participate in this program. Government gives half, the factory owner gives half. So there are about more than 100,000 plus 150,000 employees who are in this, and they run over 65 schools, which have 47,000 kids enrolled. So there is a subset of population which is already enrolled. They are in a database. They don't have to pay anything. So we thought we'd start the project with them. So we had an MOU with the PSSI's Institute of Cardiology, spoke with Arman, and he was very kind to include me into APCNA. So APCNA has Johns Hopkins and Pakistan American Cardio, PACTS, which Faisal Chima is sitting right there. So Faisal and I have been privileged to start this PACTS Foundation, which is the group of about 80 plus Pakistani origin cardiac surgeons practicing in the United States and in Pakistan as well, but they're all US trained. And then we have, once this project matures in Punjab, then we will move it to SIUT, because SIUT is again has a huge number, has a huge outreach. It is independent of government interference. And then we are also in partnership with Child Life Foundation, who run 14 emergency rooms. So the Punjab government has allocated 2 billion rupees for this project to develop a center of excellence for rheumatic heart disease management at PESSI's Rahmatullah Institute of Cardiology. We started that program last month, May, end of May, and we have already started the screening. APCNA, Nadeem Faruqi is sitting right there. Nadeem has been kind and he gave me 2 butterfly machines which I brought to Pakistan, and they have already started doing that. Now there's a summer vacation, so as soon as the summer vacation finishes, they will start doing that again. They will be, the cardiology fellows will be going into these schools. So our plan is to within a year we screen 47,000 children who go to the welfare run schools. I will just briefly mention the surgical part of this. Traditionally, the rheumatic heart disease has been dealt with by replacing the valves. And since they're young people, they're all having mechanical valve replacements, and that means that they have to be on warfarin. Now there are 20 years old plus women, and 70% of the rheumatic mitral valve is in women. So I'm just going to quickly say, this is a picture of a rheumatic mitral valve, which is predominantly regurgitant, but moderate stenosis. You can see the thickness of the leaflets, and this is after repair. You can see the lucid leaflets. This technique actually is not new. Dr. Chima, God bless his soul, was the head of the PIC. He started scaling the leaflets to make them pliable. And then you can cut the cords and you can replace the cords. So this is one of the patients we did. She's 30 years old. And since the commercially available rings are about $2,000 a pop, and nobody imports them because the market is not there. So this is just a video. If I could just run it just a little bit. Anyway, I don't want to waste time.
It's a PDF format.
PDF, so
I don't think it's going to play.
Okay,
It's
that's
not a PowerPoint.
So anyway, we started making these rings ourselves from a triple lumen catheter with a template using the the ring sizer, and putting in a sternal wire. This costs about $9 because a triple lumen catheter is about 2,100 rupees a pop, and the sternal wires are already open, so you just take part of it. So this is one rheumatic valve that we repaired in early June. He's 13 years old. You can see his heart size. He came in with heart failure. This is his incision. We did we did mitral and tricuspid repair. And this is him 2 days post-op. Anyway, it's an orphan disease. I think the emphasis should be right now that we develop techniques and spread them in Pakistan, where at least we can repair 60 to 70% of these valves, and they can be done. It's reproducible, and only about maybe 10 to 15% of these patients will require another operation 20 to 30 years down the line. And that's the goal. So inshallah, maybe in a year or two, I will come back if I'm still alive and still can walk and present you the rest. Thank you very much. Is that the literacy we really have to mitigate the positive literacy. And I talked to Dunia Television. They fortunately have had a relationship with the owner for the last 25, 30 years. And they have given us a free platform to disseminate the knowledge, both in Urdu as well as in English. Mostly it should be in Urdu because most people, our audience, our target, people who can understand.
Thank you, Rajvi. So for the sake of time, we may just take one quick question if we have one, or we can skip it for the towards the end as well. And if not, then I'll have Tamur Gill. And then next speaker.
Just one quick housekeeping thing. We're going to distribute this journal. This is actually a supplement of Pakistan Heart Journal that was specifically created for APPNA Spring Meeting. So a lot of our medical students, doctors who are doing cardiology in the US, and a lot of folks, cardiology folks from Pakistan, submitted abstracts to APPNA Spring, and they went through YPN and whole academic effort. So it's pretty neat. It's just like the supplement for ACC that you see or TCT. So thanks to Pakistan Heart Journal, we had to get this imported, and that was a fair bit of process. This is all in your bags, but I'm sure you've never looked at it or threw it away, so I brought it out here.
Any other questions?
Thanks. I'm going to introduce Dr. Tayyip Pasha. He's an ex-professor of cardiac surgery at Loival Medical College Hospital and currently consultant cardiac surgeon at National Defense Hospital. We really appreciate you coming, flying all the way from Pakistan to Lahore to the US to talk. Thank you so much.
Before you start, I just have some housekeeping rules to help our speakers. I'll have a timer here, so for a 15-minute talk, and we'll have some stuff. Thank you.
Can you bring the mic closer to you? You're having a hard time.
I'm Dr. Tayyip Pasha, recently retired as a professor of cardiac surgery from Islamic Medical College, and which is a multidisciplinary hospital. I'm nowadays working as professor of cardiac surgery at National Defense Hospital. And one more thing to that, few of my friends were building a qualitative and affordable healthcare hospital in the vicinity of Lahore, close to Shata, which is a 5-bedded state-of-the-art hospital.
Can we have you hold a mic because we can't hear very well, and I've tried to get this closer to you.
Yes, it's better now. Yeah. I have nothing to disclose. What I'm going to present is one of the long-term follow-up after coronary bypass surgery, and all of my talk is related to the our training program at Islamic Medical College, where we were doing around about 200 cases of open heart surgery in a year, as compared to my private practice, where we are doing close to 500 open heart in a year. Islamic Medical College, as you know, is a multidisciplinary hospital. We started with our training program in 2011, and till now our team has trained more than 15 postgraduate cardiac surgeons. 4 of them are working in PIC, and 1 is working abroad. From the day of inspection, all of our patients are on database, and we have got a separate person who's doing the entries as well as doing long-term follow-up. Radiology is a very vibrant and adaptable graph. That's why it has been included as class 1 indication for coronary bypass surgery. There are two components of my study. One is the unmatched population, unmatched patients, and other ones are the matched patients. I'm going to explain to you in a while. This is the WHO questionnaire, quality of life performer 5, with 5 subsets of questions, 5 and 25 subsets of questions, and we added a few more questions to that as of follow-up expiry and cause of death, use of medications, and readmission for angiography, angioplasty, radio bypass procedure. There were total 1,059 patients, 277 patients, close to 27 to 30% received radiography graft. One thing more, 95% of our practice at Islamic Medical College is off-from coronary bypass surgery. And you know, as we've got many trainings, so we have got different simultaneous projects going on, such as completeness of revascularization with off-from coronary bypass surgery, then the graft patency with off-from coronary bypass surgery, then the long-term outcome in coronary bypass surgery with poor ejection fraction. So these are all simultaneously ongoing projects. Patient with follow-up, we were able to do the follow-up of around about 70% of our patients. We couldn't do in 30% of our patients due to the COVID and due to the PTA, Pakistan Delegate Patient Authorities. You know, previously patients, published used to have 5 or 6 SIMs. You know, then there was a change in that policy, and so. But still, I think it's one of the long, 7% follow-up. So you can see there was 221 patients with the radiography and 484 with the surface with graft. Then there is another group, that's the progressive match analysis group, analyze group, in which we, on the basis of age, ejection fraction, and status of diabetes, we did progressive match analysis for them. This is the comparison of post-CABG survival between radiography and surface vein graft. This is the real and actual data. The survival status you can see. There is not much difference between with the survival pattern, but there is a significant difference regarding age. Similarly for diabetes. 16% patients were having low ejection fraction, less than 35% in the surface vein group, and 13% in radiography.